Hi, everyone. Welcome to the Advanced Pharmacology Study Review. I hope that you're going to find this helpful. We will be doing a live session on Tuesday for our Tuesday morning session. I thought it would be good for you to have this to review before our meeting as opposed to um, doing it today. So let's see how this works. All right. So when we're talking about NP practice, and remember, this is going to cover all material from week 1 to week 6. Um, so we're going to start out talking about NP professional practice. Uh, it is inclusive of many things, including prescriptive authority, collaborative agreements, and the state scope of practice laws. Now, every state, now remember, as a republic, each state is responsible for the implementation of laws. And in the state of Illinois, we have a Nurse Practice Act, as does each of the 50 states. And the Nurse Practice Act dictates the extent of privileges that we are allowed to practice as nurse practitioners in the state of Illinois. Now, each state is a little different. So each state may have different laws or restrictions. So if you're practicing in the state of Illinois, it's very important to have a good understanding of the rules and regulations that you will be working under as a nurse practitioner. Now, also, that a caveat to that is if you move and elect to practice in another state, it's important for you to gain an understanding of the rules and regulations in that state because they may very well differ from the state of Illinois. Now, currently, in the state of Illinois, you must have a collaborative physician for a certain period of time as a new grad. So you must accomplish 3,000 clinical practice hours and, oh my gosh, I cannot recall exactly how many continuing education hours. Um, uh, I'm looking it up right now. So, so in the state of Illinois, to gain full practice authority, you have to submit documentation of certification, your clinical hours, and continuing education hours. Um, and let's see, how many continuing education hours? I'm at my daughter's house, so if you hear my grandson. Um, so, in the state of Illinois, you have to have 3,000 hours of clinical work under a collaborative physician, and then you need to have at least 250 hours of continuing education or training. Now, also be mindful of the fact that as a nurse practitioner, you will hold 2 licenses. You will hold, actually, you'll have 3. You'll have your registered nurse license, you'll have your advanced practice license, and you will also have a controlled substance license. So every 2 years, you'll need to renew all 3 of those licenses until you are able to qualify and meet the requirements to gain full practice authority. Then, after you gain full practice authority, you will have that full practice authority advanced practice nurse's license and the controlled substance license. So, um, let me see. I want to make sure I'm going over everything that we need to know. So, we'll talk a little bit more about the requirements of nurse practitioners in the state of Illinois and other states as we move forward in this presentation. All right, let's talk about controlled substance. So all advanced practice registered nurses need to have a controlled substance license in the state of Illinois, and we also need to have a DEA. And a DEA license is one that we have to apply for through the Drug Enforcement Agency, and we need to renew that every 5 years, and that is a little under $900 for that. So these things can get pricey. Um, and it's interesting, in your collaborative agreement with your physician, it will list explicitly what you have the authority to prescribe under your contract, because that collaborative agreement essentially is a contract with a physician. It will identify exactly what you can now prescribe as far as narcotics are concerned. So a Schedule 2 medication, that is going to be governed by the DEA. And it will also be specifically listed in your collaborating physician whether you can or cannot prescribe those medications. I have worked in my career with collaborative agreements where we did not prescribe any narcotics, even though we had the authority to do so. My collaborating physician didn't want us to, so we couldn't. Now, after all these years, I have full practice authority, and so I can, under the guidelines, prescribe um, narcotics. There are certain things I cannot prescribe, even with full practice authority in the state of Illinois, with where narcotics are concerned, such as opioids. But it's not a big deal to me because I don't want to prescribe opioids anyway. But I can prescribe, as long as I can prescribe my codeine cough medicine and my benzos to my patients who desperately need them, I'm okay with that. But that is, um, these are all restrictions that many other states do not have. And so you might want to consider, how do these changes or restrictions get put into place? Well, we have a Nurse Practice Act, and that Nurse Practice Act is voted on by the Congress in the state of Illinois. And we have representatives that will petition for certain things to be added or retracted from the Nurse Practice Act. So I strongly encourage all nurses to become a part of professional organizations. The Illinois Society of Advanced Practice Nurses has a student, has a what do you, by the way, a membership, which is much less expensive. So does the American Nurses Association, which has a Illinois chapter. Many of the other states don't have state representation for ANA, but Illinois does. And I am actively involved in both organizations. And these organizations lobby for us, and they go to the state legislature and they petition to have changes made. It was through their hard work that we were able to achieve independent practice and get our full practice authority. They also worked a couple of years ago to get restrictions on benzodiazepines removed. This year, their focus is on certified nurse anesthetists and getting them full practice authority. So that's how change is made in our workplace or in our field of advanced practice nursing. So it's a great idea to get involved in the organization. We have an event coming up in the next couple of months I'll post some information, but it is the Student March on the Capitol. It's done every year, and we encourage students to go down to the Capitol. It's a huge event. There are a lot of speakers and things going on. I think everybody should go at least once. It's really a great event. All right. So now there are some circumstances where you can be in violation of controlled substance um, distribution. And one of those, for example, is prescribing opioids without proper documentation. And I need to also, even if it's something as simple as codeine, I have to support why I'm prescribing it, that the patient has a cough, it's uncontrolled by over-the-counter medications, those sorts of things are going to support the fact that I have prescribed a narcotic. Other things that you want to consider. A patient perhaps says they lost their medication, they lost their alprazolam, and they need an early refill. Um, what are you going to do about that? Well, I'm going to review their PDMP data, which is a bank that tells us what the patient is using as far as their medication usage is concerned, so I can see if there's a potential for abuse there. I have to tell you, when it comes to benzos or narcotics, I'm very hesitant to refill if they lost their medication. It's not one of those things that is going to pose loss of life if they don't take it until their prescription is due. Certain factors that influence prescriptive authority at the state level is the State Board of Nursing. So the State Board of Nursing is also very involved, and fortunately, we have a very strong lobby with the Illinois Society of Advanced Practice Nurses that supports us. They want us to work to the full extent of our licensure, and we're very, very fortunate to have such a good organization on our side. So, what action would demonstrate safe opioid practice? Well, we want to ensure anytime, and this is pretty much with any medication, that we're using the lowest effective dose and duration of treatment. So I'm not going to start out a patient, say, on Xanax, 1 milligram 3 times a day. Um, that would knock them out. Let's do 0.25. And perhaps if this is a situational thing, it's going to alleviate the symptoms for a while and they'll come down off of it and we'll never have to go up. But you always want to start out on a low dose. All right. So, in malpractice risk, again, documentation standards, we want to ensure we are documenting why we're using it, what dose we're choosing, why we've chosen that dose. So we really need to make sure that we are being very we're very explicit in why we're doing what we're doing. Always follow evidence-based prescribing and the use of clinical decision support tools when you are prescribing any kind of medication. And I found, I was a nursing director for 5 years in Women and Infant Service Unit. And Women and Infant Services is the second highest sued department in medicine, second only to neuro. So I spent a lot of time defending cases so that they didn't go to court or that they got settled. And the one thing that I learned was that if you follow the clinical decision support tools and evidence-based practice standards, you're good to go. It's when you go off of those it's pretty hard to defend yourself. Of course, not saying that you can't defend yourself. If you have documented well as to why you've chosen the method that you've chosen, you may be okay. But personally, I prefer to follow the standards. If I am not able to provide the care needed following the standards, I'm going to send them perhaps to pain management or psychiatry, somebody who has a higher level of clinical experience in that particular field. I'm family practice, so I see a whole genre of different conditions where they are more specific to specific conditions. Ethical prescribing, we need to ensure that we are avoiding conflicts of interest. And I remember years ago when I first started, pharmaceutical companies would just pop up all over the place. And they would give out pens and all sorts of little tchotchkes just in samples in the hopes that you would begin to use their medications. Well, that's not the case any longer. They have put great restraint on what prescribers can, or actually what pharmaceutical companies can and cannot do in the workplace as far as compensation. Basically, it's down to educational offerings. So, if they can offer an educational offering where they can provide like a dinner and but no more freebies, and it used to be a big thing. So let's talk about, we're going to switch gears a little bit here and talk about the pharmacology foundations. And those foundations include pharmacokinetics, the absorption, distribution, metabolism, and excretion of drugs. And one of the concepts associated with that is okay. So we're going to switch gears now and we're going to talk about foundational pharmacology. Foundational pharmacology includes first pass metabolism and bioavailability concepts. Now, a drug with first pass metabolism is going to require higher oral doses to compensate for that. So remember, first pass metabolism and bioavailability concepts. That first pass is going to require a higher oral dose. And when we're looking at loading doses of medications, which pharmacokinetic parameter determines that? So the volume of distribution. So we need to identify how that volume of medication is distributed in the body. Where is it going? What is it doing, to help identify what the loading dose of our patient is going to be. And that varies. It may not be the same for everybody. Okay. And here we talked about half-life and loading versus maintenance dosing. So loading dose may be where we're going to give a higher dose, and it's going to just to get it going. Like for example, Zithromax. We always double the dose of Zithromax day one, and then on day 2 through 5, it is half of that dose, or 250. So day one it's 500. That's like a loading dose, and then day 2 through 5 is 250. So a steady state is typically reached after about 4 to 5 half-lives. And remember, now I'm going to digress a little bit here, but I use prednisone a lot in clinic. Prednisone is a corticosteroid. It is an anti-inflammatory action, and it is a wonderful but dangerous drug. Okay, so I need to ensure that I am prescribing it in a manner that is going to be safe and effective. So I will typically load them up with a high dose in the beginning and wean them off. That's called a taper. So the loading dose may be 40 milligrams a day for 3 days, and then I'm going to go with 30 milligrams a day for 3 days. This is someone who's having an acute exacerbation of asthma or COPD, but I will wean them off. Now, the prednisone has a specific half-life. All right, so let me see if I can find out what that is. So the half-life of prednisone is, let me see if I can find it. Okay, prednisone half-life is 3 to 4 hours. Okay, but so that is the plasma half-life. The biologic half-life is a little bit different. The biologic half-life is a little bit longer. Mornings, when you're giving it, the biologic half-life is about 12 to 36 hours. So prednisone is considered an intermediate acting glucocorticoid. Now, some providers will, so let's go back to that asthmatic patient that's getting 40 milligrams of prednisone for 3 days. Some providers will say take that 40 milligrams all at once in the morning and you're good, right? I think perhaps since I'm an asthmatic and I have been on prednisone multiple times in my life, I don't adhere to that in my prescriptive authority, I guess you could say, because I know that the biologic half-life is 12 to 36 hours. So after I say after 12 hours, it's starting to wean. So if I gave them that full dose, they're not getting that coverage for a full 24 hours, I see in my mind. So I have them do 20 milligrams every 12 hours for 3 days. And then I have them do, you know, or yeah, 20 milligrams twice a day or every 12 hours for 3 days. And I do the same thing every 12 hours throughout the duration of their treatment. And that's how I prescribe. Now, in your clinical practice, you may find that that's not the case, that your provider that you're working with doesn't do it that way. And that's fine. That doesn't mean that they're wrong. It just means that they're different, and that they are prescribing things differently. And that's okay. Competitive antagonist. Um, So a competitive antagonist shifts the dose response curve. All right. And it shifts it to the right. So we want to remember that. And when we're looking about foundational pharmacology and cytochrome P450, interactions and enzyme induction inhibition, there are some drugs that will be deemed ineffective if a patient drinks not grape juice, grapefruit juice. So you need to, as part of your teaching, advise the patient that they cannot have grape juice. Grape juice. Why do I want to keep saying grape juice? Um, and so, and it's a lot of these in drugs are influenced by the cytochrome P450 pathway. A lot of them. All right. So let's go back here. I missed one here. All right. So let's talk about patients who are at a high risk of drug interactions. So, patients who can be at a high risk of drug interactions are that typically that 80-year-old that's on 10 different medications. One of the challenges, I'm sure you see this in the hospital, is that you have, a patient that has 10 different specialists working with them, and they're on 10 different medications, and one doctor doesn't know what the other doctor is prescribing. So that poses a huge problem, right? Oh, oh, I wanted to say something else about the CYP3A4 inhibition. That will cause increased drug levels. So you need to know. I mean, they have to have a good functioning liver to be on drugs that go through that pathway. Um, a narrow therapeutic index drug requires routine therapeutic monitoring. For example, now they don't use this drug very often anymore. Theophylline, patients needed to have their theophylline levels measured, um, and also lithium has to their levels need to be measured. There are many warfarin. You need to check an INR on those patients. So many drugs need follow up, or you just can't put them on them and never see them again. Let's talk a little bit about corticosteroids. If a patient's going to be on long-term corticosteroid therapy, it is suppressing the immune system, leaves them more likely to develop illness, increase blood sugar, especially in diabetic patients. It can also cause bone loss. So it's a great drug, and again, it's not without its side effects. Now, these drugs are the new up and coming drugs, immune system drugs, DMARDs and biologic. Now, some of them have been around a long time, like methotrexate, Remicade. They've been around for decades, but some of the new ones, like Dupixent and those that you will see advertised on television, they're relatively new, and you need to monitor these patients closely um, for things like liver. You want to do a liver function test on these patients. You always want to do a TB screen before you start um, treatment on any immune suppressant drugs or biologics. And there are certain things that you're going to advise the patient on a biologic. I advise my patients because they are immune suppressive drugs that they need to be they need to heighten their level of consciousness regarding exposure to illness. Um, and TNF alpha inhibitors, this was one of the first biologics that came to fruition and became readily available to the public. And they make these names impossible to say. Um, Adalimumab. That's how you say that name. But that's one of the first, um, and I much prefer the the name brands because at least you can say those. But they they all end in a mab. So the TNFs, they all ended in a mab. So you can tell that that's a TMF or a TNF. Come on, what am I doing here? So you can tell that by looking at the last three. Oh, okay. There we go. And the name brand for that one is Humira, and Humira was one of the first fully human monoclonal antibodies that were developed. Um, Something to consider with patients who are on these biologics is that live vaccines are contraindicated. So make sure that your patients are up to date with every vaccine before they start. So think about it. What inactivated, what live vaccines could be of issue? Uh, Shingles, the shingles vaccine for sure. Although they may not qualify for age if they're too young. MMR uh, is another one. Varicella. So no live vaccines if they're on a TNF. And this is what I guess I got ahead of myself on my slide, but that's TNF, no live vaccines, and you're going to do the TB test prior. Okay. Also, if we're doing biologic therapy, we always want to do that TB screen. So don't forget about that TB screen prior to treatment. All right, let's go to the next slide. So, immunosuppressants in transplant and autoimmune conditions. Well, let's just talk briefly about this. Immune system drugs, immune suppressants, they are amazing. I think they are cutting edge in medicine today. They are being used often now in cancer treatment, in MS treatment, I mean, in psoriasis and eczema. I mean, there are just countless medical conditions that these immune suppressants are being used for. And think about it. You have a population of people who have overactive immune systems or autoimmune disorders. Think about it. Diabetes, asthma, eczema, psoriasis, those are all autoimmune disorders, lupus. So the immune system is not functioning as it should. It is overreacting and it sees its normal body cells as invaders and destroys them. In diabetes, it destroys the islet cells in the pancreas. So these TNF blockers slow that down. It reduces the body's ability to attack itself. And that's great, right? The same thing with transplants. Their patient who suffers from a transplant is on immune suppressants because we want to prevent the body from reacting to this invader. And wonderful drugs, but not without risk. It puts you at a much greater risk of developing infection. We need to monitor labs. Liver enzymes is a big one. And certain things, and you don't need to know this for the exam, but if someone is on like Plaquenil, which is one of the older drugs we used, they need to have eye exams every so often. I can't remember if it's every year or every 6 months because it can cause issues with their. Now, vaccines, lots of vaccines out there. We have vaccines that are live attenuated, and then we have those that are not. Live attenuated vaccines are weakened vaccines, but still live, like MMR, rubella, varicella, shingles. Those are all live attenuated vaccines. The other vaccines like Tdap, hepatitis B, influenza, all of those are inactivated vaccines. There's one caveat though. The nasal influenza, which I don't even know if they do anymore, that one is a um, live attenuated vaccine. All right. So Anaphylaxis after a prior vaccine dose. I don't know why I keep losing my space here. It is an absolute contraindication for them getting a vaccine again. So if the patient has an anaphylactic reaction to Tdap, not getting any more Tdaps. That is an absolute contraindication for that patient to get another vaccine. Now, think about the COVID vaccine and the RSV vaccine. Those are different vaccines. Those are mRNA vaccines, and they're a little different. mRNA vaccines work um, by, oh, I keep touching the wrong mouse. That's what I'm doing. By providing genetic instructions for an antigen to be produced against the disease. So it actually it causes an interference in the DNA. So mRNA vaccines are different from live, they're different from inactivated vaccines. Okay, so let's talk a little bit about storage and handling of vaccines. And vaccines need to be appropriately managed. So, all vaccines need to be kept at a constant temperature. They need to be refrigerated, most of them. Some need to be frozen. So, the shingles vaccine and the varicella vaccine need to be frozen. So, monitoring the temperatures daily in where the vaccines are being maintained is incredibly important, and it is a regulation, so something that we need to do. Also, patients are supposed to be given an information sheet prior to the administration of any vaccine. Now, something that is new in my world is a vaccine that's recommended during each pregnancy now is a Tdap. So Tdap is given. All right. And what's herd immunity? Herd immunity is it protects immunocompromised individuals, and herd immunity is essentially a natural immunity to something. It's when enough people in the population are immune to an infectious disease, it makes the person-to-person spread very unlikely. So we have so many people vaccinated, the likelihood of you getting a terrible disease is low. Adverse events like an anaphylaxis needs to be reported. Okay, where am I at? And I don't want you to have memorize anything, but you should have a standard understanding of adult immunization schedules in special populations. So an adult should be receiving a tetanus shot at least every 10 years. Over the age of 50, shingles vaccine. Over the age of 65, or if you have a lung disorder, or did they decrease it to 60? Pneumonia vaccine. Over the age of 50, RSV. So have a decent understanding. I ask my patients at each visit whether they're sick or not sick, if they're up to date with their immunizations, and they'll say yes, and I'll say, "Have you had a tetanus shot within the last 10 years?" No. Well, we might need a tetanus shot then. All right, now we're going to talk about antimicrobials. And when you are deciding what antimicrobial to prescribe, remember you need to go back to what is my purpose here? Why? what is my purpose? My purpose is to kill the bacteria causing the infection. Well, I think the patient has MRSA, so I'm going to prescribe a medication that I know is going to kill MRSA. Bactrim, for example, is a good medication for MRSA. Let's talk about fluoroquinolones, a great drug, very broad spectrum, kill a lot of things, but they can cause tendon rupture. So I always advise my patients that if you begin to have um, joint pain when you're on this medication, stop it and call me. Um, Macrolides, great drugs, not utilized nearly as much as they were back in the day, but they can cause QT prolongation. So if I have a patient who already has a cardiac issue, I'm not giving them a Z-Pak. So you need to know these specifics in practice. And let's talk a little bit about beta-lactam mechanisms and antibiotics. What is a beta-lactam antibiotic? Well, augmentin, amoxicillin clavulinate. It's the clavulinate which is that makes that amoxicillin beta-lactam antibiotic. So their bacteria will release this, and this augmentin inhibits cell wall synthesis. So it makes it so that the bacteria cannot go into the cell wall. So again, you need to know what medications you need to use this on. For example, the Infectious Disease Society of America is the organization that dictates the medications that we will use for infectious diseases. Acute sinusitis. Acute sinusitis, the first line drug of choice is augmentin, because most commonly the bacteria that causes acute sinusitis is beta-lactam sensitive. So amoxicillin may work, but you have to use extremely high dose of 1,000 milligrams twice a day. And so I generally just go ahead and prescribe augmentin. If they're allergic to augmentin, then doxycycline 100 milligrams twice a day is the drug that we're going to use. So let's talk about bacteriostatic. Doxycycline, the mechanism of action is bacteriostatic. And ESBL organisms are resistant to what? Third generation cephalosporins. So again, see how I'm going back to the fact that you need to know what you're working with. You need to know what bacteria is most common to cause ear infections or urinary tract infections. So um, I was just thinking, ESBL stands for extended spectrum beta lactamase, and these bacteria produce enzymes that break down certain beta lactam antibiotics. So most commonly it's going to be E. coli, uh, Klebsiella pneumoniae, or Enterobacterales. Those are the ones most common. Okay. Um, they're resistant to penicillins, so we don't want to use those. Or third generation cephalosporins. So how do you would need to know what a third generation cephalosporin is. And one of the most commonly prescribed ones, ceftonir, that's a third generation. So we can't use it. So what are we going to use? We can use fosfomycin, nitrofurantoin, Bactrim. Those will work. Carbapenem is the first line for those specific patients. And we spoke about this one already. The key considerations of these drugs. Um, Macrolides and tetracyclines can cause diarrhea. Ooh, 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 ooh. I lost my spot. And fluoroquinolones. Renal dosing and toxicity, it's going to be the most important with aminoglycosides. Why? Because they are excreted through the kidneys. They break down in the kidney. All right. Antimicrobial stewardship principles is that we only use antibiotics when we absolutely have to. So we're not jumping on the gun the first time because I have so many patients who come in and then I ask them, the first question is, how long have you been having these symptoms? And some of them will say they started yesterday. Well, the sinus infection didn't start yesterday. And I explained to them 90% of all illness is bacterial in nature. Or no, oh my gosh, that's wrong. 90% of all illness is viral in nature. And these viruses invade and cause runny nose, congestion, and cough. And occasionally, if the symptoms last beyond 10 to 14 days, bacteria may have grown and multiplied and caused acute sinusitis. Now, there are some um, exceptions to that. If you have a patient with chronic sinusitis, you have a patient with previous sinus surgery or nasal polyps, they may develop a sinus infection more frequently, but um, that's definitely not on the lower. Oh, now what antibiotic increases the risk of C. diff? If you don't know this one, clindamycin. I use it when I have to. I try not to because of that. All right. Now, first line drug of choice for bacterial conjunctivitis. Now, I'm going to tell you this. You This is again clinical practice guidelines. You may not be seeing it in your practice at all, but the first line treatment for bacterial conjunctivitis is erythromycin ointment. And witch drop is going to be contraindicated in a corneal abrasion. No topical steroids. So you do not want to use a topical steroid in a patient that you think may have a corneal abrasion. So fluorescein staining is always a good option in the event that you want to prescribe an eye drop that has a steroid in it. I have a physician that I work with who states that you should never use a steroid in an eye at our level. That if you think that the patient needs a steroid eye drop, they should be evaluated by ophthalmology. The only time a patient really needs a steroid is when they have iritis, which is an inflammation of the iris, which happens in patients who wear contacts. An ear infection, first line drug of choice is going to be amoxicillin. And, oh, I talked about this already. Okay, so amoxicillin, and in an adult, it's 875 milligrams twice a day for 10 days. In a child, it's 80 to 90 milligrams per kilogram per day, divided by 2 or 3, and not to exceed 875 milligrams a dose. All right. Neomycin eardrop should definitely not be used if you're concerned that there is a tympanic membrane rupture. If you want to dispense eardrops and you think that the child may have, or the patient may have an eardrum rupture, you can only use ofloxacin. Oh, we talked about eye and ear vestibular suppressants, and vertigo management. 90% of all vertigo is caused by dysfunction in the inner ear. I will treat them with a Zofran if they're experiencing nausea. I will give them Anzimet for dizziness and send them to ENT. All right. All right, I've gotten ahead of myself here. All right. So let's talk about ANS and CNS drugs and sympathetic versus parasympathetic receptor actions. So benzodiazepines, they enhance GABA. So that's their function. That's how they function. Um, and I don't know what this blood pressure question is doing up here. I don't want that there, but that's the case. It's just something I'm looking at. Sorry about that. And SSRI levels increase the levels of serotonin. So think about it. They're a serotonin uptake inhibitor. So what does that mean? It means that we don't allow that serotonin to be reabsorbed. All right. Alpha and beta agonists. All right. Let me go back here. All right, one more. No, I still don't want that one. Sorry about that. I messed up on my notes. All right, so let's talk some more about ANS and CNS conditions. Um, and anticholinergic effects of these types of medications can cause urinary retention. So we need to know the I&O on these patients, and we need to educate them. Levodopa, used to treat Parkinson's disease. Opioid overdose treatment, we all know that one. Naloxone or Narcan. All right. And we spoke about this already. And this. Let's talk a little bit about endocrine drugs. And it seems like everybody is on an SGLT2 inhibitor. Now, these increase the risk of UTIs. So, oh, I'm looking at the wrong one. No. SGLT2 inhibitors. So, that's going to increase the patient's risk of a UTI. Okay. So those are specifically, I don't have, I need to know. I need to know. Um, so these drugs are used a lot in diabetes, but they're also used in weight reduction. And again, as I said, it can increase the risk of UTI. Oral hypoglycemics, metformin. Think about the mechanism of action of these drugs. How does it work? Does it make the cells more permeable to insulin, or does it make insulin more prevalent? Think about that. All right, so let's consider thyroid hormone replacement dosing principles. Levothyroxine should be taken on an empty stomach, typically first thing in the morning, and to take it as they should, they really should not take any other medications within a 2 to 4 hour window of having taken that. Cortisol replacement and adrenal suppression risks. Well, this goes back down to the use of long-term corticosteroids. It can cause Cushing features, which is that brown face. It can also cause water retention. Hyperthyroid is treated with a drug called methimazole. And but I have to tell you, most patients who suffer from hyperthyroidism, they have their thyroid either radiated or removed, and then they take levothyroxine the rest of their life. At least that's what I've seen. All right, we're getting to the end here. Let's talk about cardiovascular drugs, which you're going to be seeing a lot of. ACE inhibitors, contraindicated in pregnancy. In fact, I had a patient in clinic not long ago. One of the nurse practitioners had a patient with hypertension, and she was pregnant, and she was on a medication contraindicated. So she sent out a message, and I said, nope, she needs to stop it. She can't be on that. She needs to be on a different medication. All right. Some of the common side effects of ACE inhibitors: dry cough. It's that darn dry cough. So if you're putting someone on an ACE inhibitor, that's one of the things that you need to ask them is if they're coughing. All right, lisinopril. What is lisinopril? It is one of the most commonly prescribed beta blockers. It is a beta 1 selective blocker. Oh, so sorry, I take that back. Metoprolol. It's one of the most common. It's a selective beta blocker. I looked at the wrong note. Lisinopril is one of the very, very common first line drugs that you will be using. Okay, everybody, I got a little off track here, so let me see where I'm at here. Long-term corticosteroids. I wanted to just briefly touch base on that it can cause Cushing's. I think we talked about that. So cortisol levels should be checked on those patients. We talked about the dry cough. And how do loop diuretics act? What in the loop of Henle? I think I'm getting ahead of myself here. Okay. Statins and lipid management. Statins primarily lower LDL. And warfarin, let's talk about that a little bit. Again, you need to know the INR on these patients. And heart failure and pharmacologic management, we're not going to talk about that. I took that question off the test, so don't worry about that. I hope this presentation will help you. And if you have any questions, please send me a message, and I'd be happy to clarify things. Again, we're going to do this session live on Tuesday during our ordinary session. Let's see, what time is it? I'll send out reminders for that tomorrow. But our normal session is held from 11 a.m. to 12:30 p.m. So we'll be doing it live then. Okay?